Before I kind of dive into this, I want to mention that mechanical pain was always sort of lost within that whole spectrum of back pain and leg pain in our interventional pain space in practice. Because really, when you think about it, what we did in our practice was, for mechanical pain, was radiofrequency ablation. And it just became the bread and butter, part and parcel of what we do in our practice. We were always trained in neuropathic pain. Our fellowships were focused on neuropathic pain, and we were always trying to be experts in neuromodulation therapies to take care of pain arising as a result of some disorder of the central nervous system or the peripheral nervous system. But somewhere in that whole training and practice and focusing on the symptoms and chasing the symptoms, I did not really focus on what the etiology is. So what is leading to that neuropathic pain? And it's not that we didn't focus on that, we did, but it was quite late in the triage process. It was quite late in the presentation process where we sent the patient for surgery, and if the patient came back with a structural augmentation of their spine, patient had new onset pain, maybe persistent pain. We called it failed back, and now there are new terminologies coined such as persistent spinal pain, and we were great at that. We were great in managing long-term loss in functionality or drop in functionality as a result of neuropathic pain. And somewhere a few years back, a magical solution dropped into our toolkit and toolbox, and we started focusing on that huge spectrum of patients who were involved in and suffering from that degenerative cascade. And even before we could wait and focus on the neuropathic pain, we said, how about we start chasing the etiology earlier on so that we don't end up possibly in that situation? And so that basically concept was sort of reborn in our practice once we had access to such a therapy. So again, I practice in Austin, Texas. This has been a novel therapy in my practice for a few years. How do I move the slides? Maybe is this one? Oh, great. Thank you. All right, so these are my disclosures. I'm a paid consultant for a variety of companies, including Boston Scientific, which happens to own this interspinous spacer device. So let's talk a little bit about what this procedure is quickly. So that's the little small animation video here. It's a minimally invasive procedure. That's the patient which presents with those symptoms. Small incision, a true minimally invasive procedure. You put a dilator in, swap it out with some working cannulas and create a channel where you can work. Clean up the debris by reaming that area. Go ahead and space it or size it, and then whatever the size is, you can park that appropriately sized spacer in that area. And the size 12 is probably the most common size. If any of you in the room have done this before, you'll agree with me that 10 or 12 is probably the correct size we put in. And you open that implant up, gently mallet it towards the spinal laminar line, and you park that implant as close to the laminar line as possible. And why is that? Because that is the strongest part of the spinous process, right? And these are some of the summary points of what the first evidence or the ID study showed. So it's FDA approved for 2 adjacent segments, and has a robust data for 60 months before this product was commercialized by the company in the hands of interventional pain doctors. So the question is that if truly we are in that era where we have to triage back pain and leg pain into their appropriate pain generators, then a time has come when we have to start triaging these. It's no longer about what new patient do you have a back and leg pain. When my nurse practitioner calls me about a new patient and says a back pain walked in, I said, well, stop dead there, because is it back pain? Is it the facets? Is it the bad disc? Or is it actually spinal stenosis? And now we know that we can triage these patients into the appropriate boxes or triage levels. And the only next question we have is this lumbar spinal stenosis symptomatic? So lumbar spinal stenosis is a generic term we use for the entire spinal column. And if you have a diminished area, space, or a volume in any part of the spinal column, so that you have reduced space for the neural elements. And the question really is that radiographic appearance symptomatic at all? And if it is, then this patient is parked into that box of LSS. Now, within that LSS, where before we were relying on epidurals and maybe radiofrequencies, we now have a robust therapy which falls into your algorithm of treating spine pain. So there's different kinds of LSS radiographically, right? So you have mild stenosis, moderate, and severe. Now, this has been FDA approved for symptomatic mild to moderate stenosis. The question really is, how does that fit into your real-world practice when you guys all go back on Monday, right? So you have people who have very mild symptoms, very mild radiographic evidence, and also mild symptoms. And these are patients which we have in our practice where you focus on conservative care, you focus on epidurals maybe physical therapy, and these patients do well with small doses of anti-inflammatories, right? So that's a no-brainer. And then we have patients who have late moderate to severe stenosis, who have failed a couple of rounds of your conservative therapies, and these patients were channeled from our practices to our spine surgeons to operate on, maybe augment a fusion or laminectomy or any kind of decompressive surgery. But think about it, what was happening for that long, the wide step ladder, the wide range of moderate stenosis or mild stenosis, late mild stenosis, who were symptomatic. These were patients who were sent back to us because they were not surgery candidates, and we relied on epidurals. Maybe we ended up putting a spinal cord stimulator in them. But we really did not have too many options out there. Now, you have interspinous spacer, which you can go ahead and park at the target levels and give this patient the benefit of an indirect decompression rather than pushing this patient towards a structural surgery only because we were in a roadblock. So with that, before we even dive into the concept of using an interspinous spacer and understanding how it leads to an indirect decompression, we need to understand the spine biomechanics. So cadaveric studies were done which actually showed that if you park an interspinous spacer, it actually opens up the space in not just the central part of the spinal column, but also the peripheral part of the spinal column. And that's a term I use quite often. Superion, or the use of the interspinous spacer in my practice, really led to this understanding of peripheral column stenosis, which means lateral recess stenosis, foraminal stenosis, which led to symptoms such as neurogenic claudication with or without painful radiculitis. And we all know that when we flex forward, we basically open up these spaces. And when we do extension kind activities such as standing or walking for a long amount of time, we basically go ahead and narrow that space. And so look at this table, and you'll see here that an interspinous spacer, by virtue of opening up those areas in the central canal and the peripheral part of the spinal column, leads to improvement in those symptoms. So technically, you're blocking those extension kind of activities, which leads to a limited functionality in that patient. Now, the most important question is that why do I really adopt this innovation, right? And we all come down to the fact that what is the data behind it? Why should I adopt this therapy? And it's a no-brainer that the investigational device exempt study, which was done, approved by the FDA, led to the results, which we basically, when this was introduced to me, I couldn't believe. You had 66% relief in back pain, about more than 75% relief in leg pain, and 85% reduction in the opioids. But more than that, 90% of all these patients were satisfied. This was obviously compared against an existing therapy such as X-stop. But the important thing to note here is that look at the space of neuromodulation. We are still chasing 50% relief in back pain. When we hear a novel waveform providing 50% relief in back pain or 55, 60%, we get excited. So we're talking about a therapy which was not even designed to help back pain. We were just looking at neurogenic claudication or painful claudicatory symptoms, and that provided 66% back pain relief. The amazing part of this study was that these were patients followed up for 60 months. Think about it. When we look at the space of neuromodulation and we follow patients for 12 months and 24 months outcome data, we get excited when we start seeing those results. So we're talking about 5-year follow-up of these patients from the level 1 evidence and with such remarkable results. So again, what is more important is when you adopt a new therapy is obviously the level 1 evidence or the best evidence you select which backs up this adoption. but also what does the real world scenario look like? Because what does it mean for my patient? When I tell my patient this is a great evidence, 6, 7, 8, 9, my patient says, doctor, what does it mean for me, right? Am I actually going to be that patient who gets 75% relief? And the only way you can promise that patient that relief is by comparing your real world scenario to the level 1 evidence, right? And so that's what we saw in our practice, and that's what the PRESS registry, which was post-commercialization prospective data collection about those patients who did. And clearly, 80% of those patients were satisfied. I'll tell you anecdotally, in my practice, we saw about 90% satisfaction, 70% relief in back pain, almost 80-90% relief in leg pain, but more than that, a dramatic improvement in functionality, because lumbar spinal stenosis is directly related to a drop in functionality, right? So when you do the ZCQs on these patients 6 months, a year out, you'll find that the first thing they'll come and say is that, oh, I could go for a walk, I could go and take my grandkids out, I could go ahead and do all those things which were limited. So then the question is that if this is really an innovation and new, and we are still new in this era where we have to start triaging spine pain, then how does this really fit into our algorithm, into our current algorithm, right? If we all these years relied on epidurals and RFAs and sending the patients to our surgical colleagues, then who are those patients? And so just to kind of quickly summarize so that we can go ahead and start looking for these patients in our practice and helping them timely is, patients who have had post-conservative care. So they are patients who have maybe had physical therapy, help for a short amount of time, had epidurals, and we all understand the maximum ceiling of steroids, the annual calendar dose of steroids, right, where we are sometimes limited in helping a lot of patients out only because we have reached the maximum dose of steroids. These are patients who would come back to you, and I think they deserve a run of this algorithm where you can check for radiographic evidence of stenosis and match that or couple that with their symptoms if they do have painful claudicatory symptoms. Patients who have had spinal cord stimulators, and we'll talk a couple of seconds about it. Patients who have had surgical fusion may develop adjacent segment disease. And then there are patients who are surgical candidates, but they may have numerous comorbidities by the virtue of which they're deemed non-surgical. So let's quickly talk about the post-conservative. So here you look at these studies up here. If you have patients in there who may have had a lot of epidurals, maybe transforaminal interlaminar for peripheral column stenosis, which is probably the number one indication why we all do epidurals in our practice, lateral recess and foraminal stenosis with symptomatic painful radiculitis. Those are patients where if they do have pain or claudicatory symptoms blended with painful claudication, who get relief on sitting down on flexion, those are candidates, those are patients who deserve a questionnaire, a ZCQ questionnaire to assess the baseline functionality, and those are patients who would qualify for this. Talking about spinal cord stimulators, right? So the first time when we basically went ahead and looked at patients who had had spinal cord stimulators who came back and said that my SCS was not working, what prompted us in our practice is to create an algorithm which was my SCS is not working algorithm, because that's something, managing SCS is something we all focus on in our practices, rather than, we are all great in patient selection, but I think, how do you manage a spinal cord stimulator? And what came out was a lot of these patients were doing great when they were doing smaller activities at rest, but when it came down to going for their usual long walks and standing for a long time and cooking and doing their household chores, the SCS was perceived by the patient as not being that effective. And when we went back and looked at that MRI and CT, where we saw there was radiographic evidence of stenosis, and what the patient was actually describing was a claudicatory presentation, we went ahead and did a Superion or interspinous spacer at those target levels, and these patients came back and said, Doc, my stimulator is doing great now. And the stimulator was always working, except that it just was not doing a great job for painful claudicatory symptoms. So we all understand the biomechanics of the spine. We all understand that if you immobilize the most distal part of the spine with some structural augmentation, there are changes in the vector forces in the spine, right? The degenerative cascade takes a U-turn and basically has an effect on the north of the fusion and south of the fusion. That's just, it's normal physics. It's standard physics and forces, and that's how adjacent segment disease develops. next to the fusion, right? We've all seen this. We all do stimulators and SCS therapies for failed back surgery syndrome, post-Lyme syndromes, and we've seen this. How does that manifest, right? So obviously it starts off maybe with vertebrogenic pain, discogenic pain, painful radiculitis, radiculopathy, neurogenic claudication, but eventually at some point you develop LSS, symptomatic LSS above the level of the fusion. And what we realized was that if you have a viable spinous process above the level of the fusion, then you can basically put an interspinous spacer, and it's a much easier procedure to do as compared to extending that fusion. The first 20 cases I did, I ran it with ran it by our spine surgeons, and they were like, yeah, go ahead and do this Superion. And we found that these patients had almost 70%, 75% relief in their pain. And we understand this because what's the other adjacent segment south of the fusion? We all do SI joint injections in all those patients. So the other adjacent segment example south of the fusion is sacroiliitis, right? Anytime you immobilize the spine, we see this all the time. And so it's FDA approved for symptomatic mild to moderate stenosis. But what happened in our practice was, and in a few other colleagues, that there were a lot of patients with late moderate or severe stenosis and patients who actually deserved surgery but were limited because they had comorbidities, they could not undergo the anesthetic, or the recovery would have been much, much more longer. And so a few of us basically got that, collected that data and said, well, who are those patients? They were all patients maybe in their 7th decade, 8th decade, majority of them in their late 80s and early 90s who did not qualify to be surgical candidates either because of their age or comorbidities or anesthetic risk, and they were sent back by our surgical colleagues to our practice to help them with that back and leg pain. And what we did is we basically went ahead and did a interspinous spacer at those levels for those patients. And clearly, we saw that these patients had 70% relief, 75% relief, right? And so there's a couple of papers and references at the end of the slide, which all of you have access to. But the point to note here is that in all these big 4 groups of people or patients who are in your practice, you'll find that the results mimic the ID study which was done. And in most of the cases, the results are even better than what we saw in the ID study. And that's what leads to the fact that you can adopt this therapy based on robust evidence, a real-world scenario, and then you can promise these patients success only because you had a robust evidence and real-world scenario. And I always tell my patients that, or my practice or junior doctors or fellows, that anytime a new therapy knocks at your door, you really look at 3 important points: great evidence, great real-world scenario, and is this therapy will it allow me to treat a new pool of patients where I would have been in a roadblock and would have been forced to rely on analgesics? So clearly a novel therapy which has created a novel algorithm, and so that we can help a lot of patients in the community. Thank you.